My name is Kibusi. I'm from the University of Dodoma, where I serve as the Dean, School of Nursing and Public Health. Have been working on demographic health surveys, I think since 2012, and have managed to come up with a number of publications. One of the track that I've been following is the maternal service utilization. And as we know, lots of our mothers still die in the process of giving birth, and one of the contributing factors is only a small proportion of them deliver under professional assistance. That means they either deliver at their homes or rather some other places. So I've been trying to understand the whole aspect regarding maternal service utilization. And the best resource was the demographic health surveys, which are nationally representative, and I feel like they cover a large number of variables that we can understand the whole issue about maternal service utilization. So I will just show you more of an overview of my presentation. First, I want to introduce a little bit of the different types of DHS data files, and also when to use each data file. And that means who is or is not included in each data file. Also, on understanding maternal service utilization, I have included 2 of my publications and one more of a preliminary descriptive data analysis. So we look at the predictors of IPTP uptake, which is the intermittent preventive treatment of malaria in pregnancy. And another is look at the whole aspect of health insurance coverage and how it impacts on maternal service utilization. And lastly is to look at the national HIV/AIDS response and its impact on women. And this is done using demographic health surveys from 2003 to 2012. These are like 3 different data sets that I used. This data comes from different institutions, but I won't waste time. This is how the data set looks. You have columns with the different variables and the rows representing individuals, cases. And this is the types of files available. You have the HR, which looks at human record, and the PR, more of people's. That means all household members file. And then there is an ER file, which is women and men who completed the interviews, and this is a category of people who are aged 15 to 49 years. And then there is a KR file, which represents children under 5 years of age, and the interview is done to women, their mothers, or rather somebody who's taking care of the babies. And then we have a BR file, which is the birth record, and this is birth to interviewed women in the past 6 years. And then we have the AR file, which has HIV data, test results. So this is more how the data is collected. Usually, you go to a household, you interview men and women between the age of 15 to 49 years, and then there is some information regarding children. So this whole makes one big data set. But because SPSS or Stata cannot handle hierarchical files, so these files are more put separately. So you have to find the individual or something. So this is the number. If you want to analyze household level, then you will get household data. If you want to analyze issues regarding men and women of reproductive age, 15 to 49 years, use the IR file. If your intention is to analyze data regarding children, then you use either the KR or the BR files. And usually children of non-interviewed mothers are not included. And so if you want to analyze the whole thing, then you can use the PR file, people's file, all members of household. So regarding utilization of maternal services, one aspect that I started looking is to look at the predictors for uptake of intermittent preventive treatment of malaria in pregnancy. A little bit of a background, we know that there is a high prevalence of malaria. I mean, the burden of malaria is very high in our settings. And that infection of malaria during pregnancy does not only affect the mother, but it can even affect the child, even result into death of the child. But research has shown that if a mother gets at least 2 doses of anti-malarial, of course, of the SCP regimen, they can reduce the chances of infecting the child and even save the lives of the babies. But we have had some problem when you look at the previous data. Only a third of women in our setting, they seem to take the recommended dosage. So the question is, what could be the factors that are influencing uptake of IPTP? So we used the same DHS data, from the 2012 Tanzania HIV Malaria Indicator Survey, and looking at the outcome variable regarding uptake of IPTP, which are 2 recommended doses. And our unit of analysis then will be pregnant women aged 15 to 49 years who gave live birth in the past 2 years. And looking at the questionnaire, we were able to construct a conceptual framework so we can tell what could be some of the demographic factors, some modifiable factors, and then the outcome variable, which is whether a woman is taking IPTP or not. And this is how we dealt with the data. Out of 10,000 women who are included, we selected women who had birth at least 2 years before the survey. And then, we looked at women with the complete information. So we end up with a sample of 1,615. So analysis, both descriptive and inferential statistics were done. And we look at descriptive statistics. You can look at with mothers who are a bit wealthier doing fairly better. Up to 50% of them are taking the recommended dosage, while if you look at the poorest, only 27% of them are taking. And we look at timing of the first antenatal visit. Mothers are supposed to go for their first visit during the first trimester, the first 13 weeks. So if a mother comes during the first visit, during the first trimester, up to 44% of them are taking the recommended dosage, compared with only 18% for mothers who come late during their antenatal visits. And univariate analysis to look at what sort of factors can be related with whether the mother is completing the recommended dosage or not. You can see issues around age, occupation, marital status, wealth, parity, timing of the first visit, and whether the mother knows about malaria prevention, also the zone where the mother is coming from, and where to get the antimalarials. We are related with the uptake of IPTP. When we constructed the model, so to look at the adjusted odds ratios for the factors associated with the uptake of IPTP among these women, we saw that, for example, in terms of age, there was a significant association whereby compared with the youngest mothers in the age of 30 to 35, we had higher odds of taking the recommended dosage. And also you compare married women with separated women in relationship, we are more likely to take the dosage, the recommended dosage. And also there are variation between zones. In the eastern zone, they seem to be doing better, while the other zones like in the southwest, Highland, Central, Northern, Lake, and Zanzibar had very low odds of taking the medication. And another thing is on parity, yeah, having 3 or more children was, made mothers less likely to take the medication than those without a child or at least having 1 or 2 children. And the timing was highly associated with uptake, where mothers who come during the first or second trimester had higher chances of taking the recommended dosages. I will skip the discussions for you guys to ponder, so I move to the second paper, where I looked at the health insurance as a cornerstone in improving maternal health service utilization in Tanzania. And this was also based on Tanzania HIV and malaria indicator survey. So the burden of maternal death is high, but early and planned antenatal care attendance and the facility delivery are more likely to improve the birth outcomes, but there is inequality, and also there is prominent high out-of-pocket health expenditure, despite that these services are heavily subsidized by the government. But still mothers fail to appear. Only half of the mothers actually make it to deliver in the hospitals. So then you wonder, what is the issue if the services are free? So we assessed this using the same data. And this cross-section data, we started with the 19,000 men and women. We excluded men, and then we remained with the 10,000 women, and then we only selected women who had a live birth at least in the past 3 years, and so we remained by 4,627 women. And of course, we're looking at the data set, those with complete information. At the end, we had 4,500 women. Our outcome of interest was maternal health service utilization, and the main exposure was health insurance coverage, of course, with a number of covariates included in the model. How did we define maternal service utilization? There are 3 variables in the data set. One is about the timing of the first antenatal care visit. Second is completing the recommended number of antenatal visits. Usually, a mother is recommended to have 4 more visits during pregnancy. And last is delivery in a healthcare facility. And then our independent variable will be the health insurance coverage, which is being asked any form of insurance if a mother has. So results after constructing a model, we saw that having health insurance doubled the chances of a mother to time the first visit accordingly, and also increased the chances of a mother to deliver in a hospital. But there was no association when you look at attending the recommended number of antenatal visits. And also we saw about age, rural and urban. Those in rural areas we are more likely, those in the urban areas were more likely to attend, to make a good attendance to the healthcare facility than those in urban, rural areas. Also, there was a significant difference among zones, and you can see, I won't be able to go into details. And in terms of wealth, we see mothers who are more wealthier are 3 times more likely to deliver in a hospital than those who are coming, within the poorest quintile. And unemployment also showed a significant relationship. So only 6.2% of women had health insurance, and up to 43% of these women did not deliver their last baby in a hospital. And having a health insurance was associated with the proper timing of antenatal care and also giving birth to under-skilled assistance. And lastly, to look at the impact of national response on HIV from 2002 up to 2012. We used 3 different data to look at this. The 2002, 2007, and the 2012 Tanzania HIV and malaria indicator surveys. So I've just looked at the women only. Overall, the overall prevalence of HIV has decreased from 7.7 to 60.2 over the years. But if you look at mothers who are around the age 30 to 49, those bars, I think you'll be able to tell. So HIV has not increased that much, from 12% to only 80% in some of the age groups of the mothers. We're looking at mothers in the ages around 30 to 49. And also in the same, when you look at area of residence, even though there is significant decrease in HIV prevalence among women, but mothers in rural areas, if you look at in 2003, there was a prevalence of 5.8, but come 2011, only a small decrease, up to 5.1% of mothers in rural areas have HIV. So this is also something to note. And also we look at the trend of HIV prevalence among women by pregnant status at the time of data collection. So among those who are pregnant, there is a significant decrease in the prevalence of HIV. But when you look at mothers who are not pregnant, the change is still very low. When you look at the 2003 data, up to 7.80% of them had HIV, and only a slight change, almost 20 years later, the prevalence still at 6.5%. And also we looked at trends of HIV prevalence by a number of lifetime sexual partner. We usually ask mothers to estimate the possible number of sexual partners they ever had in their lifetime. And you can see that the higher the number of reported sexual partners, the prevalence of HIV actually, among those who reported the highest number, increased from 15 to 21%. And there is a slight reduction during the 2011 survey to 18.9%. So while the national average is at 6.2, you still have people reporting HIV prevalence of around 19% of them. And we look at the prevalence of a history of HIV. These are sexually transmitted diseases. I put circles on those who reported to have a history of HIV infection. And you could see the prevalence is very high, and it has not made any significant change, from 15.1% to only 13.5% 20 years later of programming. And if you look at level of education, while there is significant decrease of HIV among those with high education, from 9.3 to 4.9, only a slight change has happened over the years among those with low education, from 7.6% to 6.4%. So, but all these are descriptive statistics. We have to go further to do more inferential analysis. So I will leave this for discussion. Otherwise, thank you for your attention. Okay, I think I should make it clear from the very beginning. I'm coming from the health industry, but I love data. So I came here and attended all this, the summer school. And somehow I felt that I think there is a need to connect I mean, yeah, what you have been learning and what I do. Otherwise, these are data that are within the SPSS starter, just other analytical softwares. And you do the usual kind of analysis without really going to the computer language and stuff. Yeah. Thank you. Oh. Yeah.
Yes, as you kept on presenting your key findings, you presented some interesting findings.
Yeah.
So I kept on wondering why you were not explaining the findings, though, because you could present key findings like trends like poorer or maybe the first dose, and then maybe the richer, then at the very end you mentioned it's descriptive data, analysis, analytic information. So I asked myself, why didn't you go ahead to maybe find out why the trends were this way or that way? Yes. Did the study not go deeper into that kind of analysis?
Okay. Yeah, I presented 3 papers. For the first and second paper, those are like complete because we did both, descriptive and inferential statistics. So whatever conclusion that we made is based on, robust analysis, and the conclusion are drawn after, adjusting for a number of possible confounders. So we didn't just, so for the last segment when I was talking about HIV, this was more descriptive. So one could still, you can't make a conclusion based on those ones. But still, they give you a picture for further analysis or for you guys to extend my work from there. Yeah. Oh, yes, ma'am.
Oh, thank you. Thank you for the presentation. How it seems like this is a very large scope. So I'm curious how you, the data, where it's stored, how you, because the conclusion seems to be based on a lot of data from the whole of Tanzania.
Yeah.
I wonder if you could give us a sense of how you went through that whole process almost from the beginning, actually getting that data into a way that you can tell us the conclusions that you have. Just maybe briefly.
Yeah. So perhaps let me show, because actually my interest to do this presentation is to tell you, especially Tanzanian computer colleagues, that there is a lot of information being generated out there regarding the health of, it's a lot of indicators, health of men, health of overpopulation. And this data has been generated since 1990s. Actually, for HIV, the first data came in 2001. But if you remember, during the same time, that's where we started to have our first national policy for HIV/AIDS. So this data is nationally representative, and I was skipping the methodology because of time. But actually, what they do is you set the country to different. You have different regions, and then from the different regions, we have what we call census enumeration areas. Those are used as clusters. So from this, each cluster, they will go and sample a number of households. That's where they go find the individuals. So when they go to a household, they interview everybody. That's why you have different types of files. Some are for household, if you want to analyze data at a household level, and some are for individuals, meaning men and women within the age group of 15 to 49 years, but also can get data for children. This is data coming from mothers who have been interviewed within the household. So once you have this data, it exists in different formats. So it could be in a starter, or you could have it in SPSS. So the next thing you have to do is to understand the variables within the data, because they say each category has its own questionnaire. So you just have to go to a variable view and try to read the different variables that are there. And somehow you need to understand, because as I think the presenter about health science yesterday mentioned, one aspect could have even 80 questions just exploring one issue. So you have to do a little bit of recording, and then at the end, you can, being able to measure a certain variable. And of course, based on the variable that are within the questionnaire, you can construct your own conceptual framework. And then, of course, there are issues. Other issues regarding this data might include linking data, because, for example, HIV test results are not included, are put separately. So you have to kind of do merging or sometimes kind of selecting the data that you want from the same variable. Otherwise, once we have a clean database, the rest is just the usual kind of analysis where you can learn frequencies, learn some of the distribution or testing for independence, and then you move on to regression or something. Yeah. The rest is just, writing of your paper. Yeah.
One more question.
And just to confirm, the DHS data set, that's publicly available, right, on the DHS website?
Sorry?
The data set,
the
national representative data set, is publicly available on the DHS website, is that correct?
Yeah, but before you publish, you have to log in there and then ask for their permission. And so you have to write your idea, and then they give you access to the data. Sometimes a bit complicated when you're accessing HIV test results. They might need to identify your institution and all that. And when you publish your paper, you have to communicate it to them as well. And if you are publishing with different countries, then make sure that you have a report that with the analysis goes to the country that you made your analysis. And another thing, I think, depending with the level of analysis, the nature of the analysis or the data you're using, the ethical part have to be well, you have to take it into consideration.
Let's thank Dr. Kibusi one more time.
Yeah, thank you.